Hello, this is Professor Capron. Welcome to today's presentation on laryngeal cancer. Let's look at the objectives for today's presentation. By the end of this presentation, you will be able to understand the types and classifications of laryngeal cancer, identify the role of nursing in managing laryngeal cancer, recognize the causes and risk factors for laryngeal cancer, describe the anatomical structure of the larynx, explain the pathophysiological mechanisms involved in laryngeal cancer, perform focused assessment of suspected laryngeal cancer patients, interpret lab tests and diagnostic procedures for laryngeal cancer, identify potential complications and the psychological aspects, apply preoperative and postoperative nursing interventions, and describe medication management and side effects. Today, we're going to focus on laryngeal cancer. Your nurse's role in the management of this specific cancer is very crucial. First, let's consider early identification. You might be the first medical professional who listens to a patient's complaint about a lingering hoarse voice or unexplained throat pain. Your observational skills and comprehensive assessment can set the course for early and potentially life saving interventions. But it doesn't stop at diagnosis. Nursing support continues through treatment, surgery, and even postoperative care. You'll guide patients through complex medication regimens and symptom management, advocate for them in a multidisciplinary team, and provide essential education that empowers them to be active participants in their own care. Your relationship with the patient extends beyond the clinical aspects. As a nurse, you'll be a trusted point of contact for patients who are coping with the emotional stress that comes with a cancer diagnosis. You'll be there to address not just physical, but also emotional and psychological needs, always with an eye towards maintaining the patient's dignity and individuality. So, as we dive into today's topic, remember the role you play is not a passive one. You're an active participant in a complex care network, providing holistic support to patients when they need it the most. And that's a role that should never be underestimated. Alterations in health. Let's get into the specifics of laryngeal cancer. What exactly is it and how do we classify it? Well, first, laryngeal cancer is a malignancy originating in the larynx or voice box. Now, it's worth noting that while the larynx is a relatively small organ, it's quite complex. It's made up of various types of tissue, each susceptible to different kinds of malignancies. The larynx can be broken down into three main regions: the supraglottis, the glottis, and the subglottis. Supraglottis. This is the upper part of the larynx above the vocal cords. Cancers here often spread to the lymph nodes early, but are less likely to infiltrate the voice box itself. Glottis. This is essentially the vocal. The tumor here can cause voice changes, a critical clue when diagnosing laryngeal cancer. And subglottis. This is the region below the vocal cords. Cancers here are the rarest and are typically discovered in later stages due to fewer noticeable early symptoms. Let's talk about classification. Cancers are generally classified based on the type of cells they originate from. Squamous cell carcinoma is the most common type, making up about 85 to 95% of all laryngeal cancers. This originates in the squamous cells lining the larynx. Adenocarcinoma is rare, but it starts in the glandular cells and has a different treatment approach compared to squamous cell carcinomas. Sarcomas are extremely rare. These begin in the muscle or connective tissue of the larynx. Knowing the type and location aids in making treatment decisions, as the effectiveness of treatments like radiation, chemotherapy, or surgery can vary significantly depending on these factors. So, when you encounter a patient with suspected laryngeal cancer, you're not just looking at some generic malignancy. You're dealing with a highly specific, localized condition that demands equally specific diagnostic and therapeutic approaches. Understanding this categorization helps you with patient education, interdisciplinary communication, and ultimately in delivering targeted and effective nursing care. Okay, now that we've gone through the types and classifications of laryngeal cancer, let's dig into some root causes. Why does laryngeal cancer begin in the first place? The big culprit? Smoking. Cigarettes, cigars, and pipe tobacco contain numerous carcinogens that directly affect the larynx. Smokeless tobacco isn't off the hook either. It's also a significant risk factor. High alcohol intake, especially when combined with smoking, magnifies the risk exponentially. Ethanol in alcoholic beverages can act as a solvent, enabling tobacco carcinogens to penetrate the cells of the larynx more easily. Workers in certain industries face heightened risks. Exposure to asbestos, wood dust, paint fumes, and certain chemicals used in the metalworking industry can contribute to laryngeal cancer. Human papillomavirus, HPV, particularly type 16 and 18, can increase the risk of laryngeal cancer. HPV associated laryngeal cancers often present differently and may have a separate treatment pathway. A diet low in fruits and vegetables can increase the risk. Antioxidants that are found in fruits and vegetables can neutralize harmful free radicals in the body, offering some protective benefits. Acid reflux can cause irritation and cellular changes in the larynx, although the evidence is not as strong as with other factors. Family history is not very well understood, but genetics may play a role, especially if there is a family history of head and neck cancers specifically. Laryngeal cancer is more common in older adults and is significantly more common in men than in women. However, the gender gap has been narrowing, likely due to changes in smoking habits. As nurses, your role in identifying these risk factors is pivotal. Proper history taking can shed light on potential risks long before symptoms manifest, offering a chance for preventive action or at least early detection. You'll be surprised about how a simple question about lifestyle or work environment can sometimes unfold critical information. And remember, etiology isn't just an exercise, it's vital for tailoring your prevention strategies and treatment plans. A patient who smokes and drinks, for example, needs immediate, targeted lifestyle intervention alongside any oncological treatment. I hope that paints a clear picture of the multiple etiological pathways leading to laryngeal cancer. Pathophysiology. Welcome to Anatomy 101 of the larynx. Understanding the structure of the larynx is pivotal for grasping the complexities of laryngeal cancer. This foundation will help us appreciate how and where this cancer can spread, affecting function and requiring specific interventions. The larynx, often referred to as the voice box, sits at the intersection of the pharynx and the trachea. Its main functions include voice production, respiration, and swallowing. The framework of the larynx is primarily made up of cartilages. These include the thyroid cartilage, also called the Adam's apple, cricoid cartilage, and paired arytenoid cartilages. These are a pair of cartilages used in the production of different kinds of voice quality. Cartilage involvement in laryngeal cancer often indicates advanced disease requiring aggressive treatment. Inside the larynx, you find the vocal cords, which are critical for sound production. They vibrate to produce sound as it flows through them. Glottic cancer, which originates on the vocal cords, often manifests early as hoarseness. Ventricles and the vestibule are spaces within the larynx. The ventricles are important to note because they produce mucus that lubricates the vocal cords. The vestibule is the uppermost part. Tumors here can obstruct airflow and are harder to detect visually. The epiglottis is a leaf shaped flap that prevents food and liquid from entering the airway during swallowing. It has both respiratory and digestive system implications, making its role critical. Intrinsic muscles control voice modulation, while extrinsic muscles support the structure and position. Muscle involvement in cancer often complicates treatment and can lead to functional losses. The recurrent laryngeal nerve, a branch of the vagus nerve, supplies the larynx. Its injury or involvement in cancer can lead to vocal paralysis. Rich blood supply means faster spread of malignancy, and the presence of lymphatics also increases the risk of metastasis. We have some subsites. The supraglottis, glottis, and subglottis are the three main anatomical regions. Knowing the site of origin of the cancer is critical for staging and treatment. As nurses, you will be directly involved in preoperative and postoperative care. Understanding this anatomy is vital for identifying symptoms and complications, communicating effectively with other healthcare providers, and educating patients. If a patient complains of difficulty swallowing, now you know to think about possible epiglottis involvement or a tumor affecting the ventricles. To paraphrase an old saying, to save the larynx, you first have to know the larynx. So keep these anatomical landmarks in mind as we explore the deeper complexities of laryngeal cancer in the. Let's move on from the anatomy to the actual disease process. Knowing how laryngeal cancer develops and progresses is crucial for effective nursing interventions, symptom identification, and patient education. Initially, there are alterations at the cellular level. You'll see dysplasia, which means abnormal cell growth. It doesn't mean cancer yet, but it's like the cells are in a rebellious phase and could go down the wrong path. The majority of laryngeal cancers are squamous cell carcinomas, originating from the epithelial cells lining the larynx. Always remember, squamous cells are the troublemakers here. As the malignant cells multiply, they invade adjacent structures. Based on our earlier discussion about anatomy, think of how this can affect voice, swallowing, and even breathing. If left untreated, these cancer cells can hitch a ride through the bloodstream or the lymphatic system and invade other organs. The lung is a frequent site, followed by bone and liver. Tumor growth can lead to obstruction in the larynx, causing respiratory distress. Immediate interventions are required to secure the airway. Paraneoplastic syndromes are rare, but can occur. This is when the tumor secretes hormones or cytokines that can affect bodily functions like coagulation or calcium metabolism. Cancer generally, and specifically here, can weaken the immune system, making the patient susceptible to infections, which complicates treatment. Advanced laryngeal cancer can cause severe weight loss and muscle wasting. Understanding this can inform nutritional interventions. Chronic inflammation can support tumor growth, while angiogenesis, the formation of new blood vessels, fuels the cancer with a fresh blood supply. As nurses, you'll be at the forefront, assessing symptoms, implementing interventions, and educating patients about these processes. For example, if a patient experiences sudden weight loss or difficulty swallowing, you can relate it back to the pathophysiology we've just discussed and understand the urgency of reporting such findings for immediate evaluation and treatment. Think of it like a leaking pipe. Catching the leak early means less damage and easier repair. The same principle applies to recognizing the pathophysiological signs of laryngeal cancer. The earlier we catch it, the better the outcomes for our patients. Health promotion and disease prevention. Now that we've demystified the pathology of laryngeal cancer, let's talk about the best medicine, prevention. The biggest, fattest culprit in the lineup of laryngeal cancer risk factors is smoking. No surprise, right? Educate patients on the strong link between smoking and laryngeal cancer. Provide resources for smoking cessation programs and medications like Chantix or nicotine replacement therapy. Drinking alcohol, especially when combined with smoking, skyrockets the risk. Harm reduction strategies such as cutting back or complete abstinence are key. Diet and nutrition. Bet you didn't see that one coming. A diet rich in fruits and vegetables lowers the risk, so push that produce and remember to discuss it during patient education. Occupational exposure to asbestos, paint fumes, or industrial chemicals can elevate risk, so educate patients about wearing protective equipment and adhering to safety guidelines in work settings. HPV is becoming increasingly implicated in head and neck cancers, including laryngeal cancer. While the HPV vaccine is often administered in adolescents, it's also approved for adults up to age 45. Voice care. Constant straining of vocal cords, especially in professions that require frequent speaking or singing, can contribute to laryngeal issues. Advise patients to take vocal rests and stay hydrated. Promote annual physicals that include a thorough examination of the neck and throat. Knowing what we discussed about the anatomy and pathology, early detection is paramount. Participate in health fairs, write articles, or give talks to raise awareness about the risk factors and preventive measures for laryngeal cancer. Yes, nurses can be educators outside the clinical setting too. Here's something to chew on. If a patient says, "Well, I've smoked for years, what's the point in quitting now?" You can say, "Well, imagine trying to fire while someone keeps throwing gasoline on it. Quitting now is like taking away the gasoline." So let's equip our patients not just with treatments, with strategies to prevent the disease in the first place. Prevention is a powerful tool, and you are its wielder. Let's focus on early detection, another crucial line of defense. Detecting laryngeal cancer in its early stages significantly increases the chances of successful treatment. Here's what you, as a nurse, need to know to catch this disease before it snowballs. If a patient mentions a hoarse voice that's lingering longer than 2 weeks, that's a red flag. Refer them for further examination. Difficulty swallowing is known medically as dysphagia. This symptom is often brushed off as an inconvenience, but it does warrant attention. If a patient experiences difficulty or discomfort in swallowing, consider it a warning sign. A sore throat that doesn't resolve or recurs frequently should not be dismissed as, oh, just another sore throat. Some people experience ear pain, even though the problem originates in the larynx. A little counterintuitive, but please remember the ear, nose, and throat are interconnected. Unexplained weight loss over a short period could signal not just laryngeal cancer, but various types of cancers. If someone's voice sounds notably airy, it might be due to weakened vocal cord closure, which could be a sign of an underlying issue. Let's look for changes in vocal quality because whether it's a lowering of pitch or roughness in tone, any change in vocal quality that persists should be investigated. During physical exams, palpate the neck area. If you detect any mass, lump, or asymmetry, it requires immediate further evaluation. Keep meticulous records of your observations and patient reports. These can be vital in tracing back the symptom onset if a diagnosis is made later. Any of these symptoms merit a referral for further diagnostics, usually starting with a laryngoscopic examination. Here is a mnemonic to make it easier for you and your patients to remember these symptoms. Hideaways: hoarseness, ingestion difficulty, ear pain, ailment of the throat, weight loss, airy voice, yucky changes in vocal quality, and suspicious lumps. Time is of the essence in cancer detection. Imagine being a detective and every clue, no matter how small, could crack the case wide open. You have the training and the tools to pick up on these early signs, so let's not let any slip through the cracks. Assessment. Risk assessment is pivotal in healthcare, and laryngeal cancer is no exception. Being able to identify risk factors informs prevention strategies and diagnostic considerations. So let's review the gamut of risk factors that you as a nurse should keep on your radar. Tobacco use is the number one culprit. If a patient is a smoker or uses any form of tobacco, their risk skyrockets. Even secondhand smoke exposure counts. While alcohol alone is a moderate risk factor, combine it with tobacco and you have a synergistic effect that substantially raises the risk profile. Jobs in mining, woodworking, and those involving chemicals like formaldehyde have been linked to an increased incidence of laryngeal cancer. Make sure to inquire about your patient's employment background. Environmental toxins include long term exposure to harmful substances like asbestos, which is particularly insidious because it can take years for symptoms to manifest. While no specific genes have been identified yet, a family history of head and neck cancers could predispose an individual to laryngeal cancer. These cancers are more common in males and those over 55. While you can't change these factors, being aware of them can inform your risk assessment. HPV infection is an increasing concern, especially with oropharyngeal cancers. While the larynx is not as commonly affected, it's worth noting any history of HPV or related cancers. Let's remember that with poor nutrition, having a lack of vitamins and antioxidants that are found in fruits and vegetables can make tissues more susceptible to cancer. Long term irritation from stomach acid can contribute to cancer risk. If a patient reports chronic heartburn or has been diagnosed with GERD, keep an eye out for other symptoms. Immunocompromised patients are at higher risk. This includes those with HIV and AIDS or those receiving medications that suppress the immune system. Lower socioeconomic status has been correlated with a higher incidence of laryngeal cancer, possibly due to reduced access to healthcare and higher rates of tobacco and alcohol use. Remember the acronym TAG HOPES for easy recall: tobacco, alcohol, gender, and age. HPV, occupational hazards, poor nutrition, environmental toxins, and socioeconomic status. Keep these risk factors in mind when performing patient assessments. Genetic predisposition is an evolving subject in the world of cancer, and the same holds true for laryngeal cancer. Though there's still a lot to learn, understanding the existing literature can help you make sound judgments in patient care. While some cancers have strong hereditary components, laryngeal cancer isn't usually one of them. There's no single cancer gene that we can test for to predict this type of cancer definitively. If there is any genetic predisposition, it's likely polygenic, meaning it involves a combination of genes, not just one. While testing for a polygenic risk score isn't standard practice yet, it is an area of active research. Family history of laryngeal or other head and neck cancers can increase the risk, but not as significantly as with certain other cancers. Nonetheless, it's crucial to take a thorough family history during your patient assessment. Some evidence suggests that genetic susceptibility might amplify the harmful effects of external risk factors like tobacco and alcohol. Studies have found associations between certain single nucleotide polymorphisms called SNPs and an increased risk of developing laryngeal cancer. However, these are more like clues in a mystery, they are not definitive proof. Research has indicated that certain ethnic and racial groups may be more susceptible to laryngeal cancer, but this data is not robust enough for us to make any conclusions. Changes in gene expression, called epigenetic factors, rather than the genes themselves, can also play a role. Epigenetic changes can occur due to environmental factors like smoking and are also a hot topic in ongoing research. While not currently recommended solely for laryngeal cancer risk, advancements in genetic screening techniques may one day allow for more targeted risk assessments. While we can't definitively say who will develop laryngeal cancer based on genetics, a suspected genetic predisposition might lead to closer monitoring and earlier diagnostic screenings. So, the science of genetics and laryngeal cancer is still very much a work in progress, but that should not deter you. Instead, see it as an opportunity to continually update your knowledge base, offering the most current and comprehensive care to your patient. Identifying the clinical manifestations of laryngeal cancer is pivotal in early diagnosis and timely intervention. Let's walk through what you'll commonly encounter. One of the earliest signs often brushed off as a cold or overuse is hoarseness or voice changes. Persistent hoarseness warrants immediate attention. Advise patients not to wait it out. Prompt evaluation is crucial. Sometimes the patient can experience persistent sore throat. While this might be a symptom of many less serious conditions, the persistence is what we're focusing on here. Difficulty in swallowing can manifest as a feeling of a lump in the throat or even while swallowing. The symptom is more commonly associated with advanced stages, but can occur earlier as well. Laryngeal stridor is a high pitched wheezing sound and it's indicative of obstruction. This is a red flag. It warrants immediate diagnostic procedures. A tracheostomy might be necessary for advanced cases where airway obstruction is imminent. Weight loss without trying can be a red flag for many cancers, not just laryngeal. Keep an eye out for this, especially if accompanied by other symptoms. The nerves in the larynx and the nerves in the ear have a very close relationship. So, laryngeal cancer can cause referred pain to the ear. And although this is less common, it is a symptom worth noting. Hemoptysis or coughing up blood is never a sign to take lightly. Any instance of this should warrant further investigation to rule out malignancy. Respiratory distress is a late stage symptom and indicates a severe condition requiring immediate intervention. Time is of the essence here. Act to secure the airway and facilitate breathing. Although more common in other types of head and neck cancers, a lump in the neck can occasionally signify metastatic laryngeal cancer. Look out for subtle alterations in the quality of voice, such as losing the ability to hit certain notes while singing. This might seem benign, but can be an early sign worth investigating. Some patients describe a feeling as though something is stuck in their throat. This may be an overlooked sign, but should not be ignored. Your nursing takeaway here is that each symptom, even if it appears minor, is a puzzle piece. Taken together, they form the larger picture that can indicate laryngeal cancer. Your role is to assess these pieces meticulously and advocate for timely diagnostic procedures. Symptom recognition in laryngeal cancer is fundamental to your role as nurses. Understanding the stages of symptoms will help you differentiate between something that needs immediate attention and what might be an early warning sign. So let's break it down. Let's look at the early stage symptoms. That's persistent hoarseness. If a patient's voice has changed and it doesn't resolve in 2 weeks, this is a symptom requiring immediate follow up. Mild sore throat. A sore throat that doesn't improve with standard treatments like antibiotics or anti inflammatories should be looked into further. Difficulty in swallowing or dysphagia, even if it's just a feeling of something being stuck, well, this symptom can't be brushed off. And patients may note that their singing range diminishes or they can't project their voices before. Late stage symptoms include laryngeal stridor. This high pitched wheezing sound indicates possible airway obstruction and demands rapid intervention, possibly a tracheostomy. Unexplained weight loss is an ominous sign in the context of other symptoms. Coughing up blood is alarming and should trigger an immediate series of diagnostic tests. And at this point, the tumor may have grown enough to obstruct the airway, making breathing difficult or impossible. This is a medical emergency. A palpable lump in the neck might indicate that cancer has metastasized. Recognizing the gradient of symptoms from early to late stage is crucial. For early stage symptoms, your role involves counseling the patient about the urgency of further evaluation, diagnostic tests, and lifestyle changes. In late stage symptoms, it's about immediate intervention and referral to specialists for rapid treatment, possibly life saving measures like securing an airway. So be vigilant. Your observations make the difference between early intervention and crisis management. When monitoring laryngeal cancer, understanding blood markers is a must. Specifically, there are two primary serum markers we need to focus on for patient monitoring in the context of this cancer: LASA and ferritin. LASA is lipid associated sialic acid. It's an established tumor marker elevated in various malignancies, including laryngeal cancer. Elevated levels of LASA often correlate with tumor burden and may be useful in initial assessment to gauge the extent of the disease and in monitoring during and post treatment to observe how well a treatment plan is working or to detect recurrence. Ferritin is typically associated with iron metabolism, but elevated ferritin levels have been found in patients with certain cancers, including laryngeal cancer. Ferritin levels may give insight into prognosis because higher levels could indicate a worse prognosis. Inflammation. Since ferritin is also an acute phase reactant, elevated levels could hint at underlying inflammation or other systemic issues. We need to integrate these markers by cross referencing. Always cross reference LASA and ferritin levels with other diagnostic methods to get a complete picture. Regularly monitor these levels for any abrupt changes, as that could signify a shift in disease status requiring immediate attention. Your role? Well, data collection. Confirm the orders for last ferritin testing, making sure the patient meets any pre-test conditions like fasting if required. And once results are in, quickly inform the medical team and prepare to discuss these with the patient in an understandable manner. While it is the doctor's role to provide this information, often the patients will turn to the nurse, and you need to be knowledgeable about how to explain things that the doctors didn't make very clear. It's not just about knowing the numbers, it's about what those numbers mean for your patient's journey. So remember, LASA and ferritin are invaluable tools for both diagnosing and monitoring laryngeal cancer. These markers are not standalone diagnostics, but they do provide crucial information when combined with other clinical data and assessments. Now that we've discussed the importance of LASA and ferritin as blood markers, let's move on to other laboratory tests that are also crucial in the management of laryngeal cancer, such as a CBC or a complete blood count. Chronic diseases like cancer often cause anemia, which would show as low hemoglobin and hematocrit. Anemia is very common in head and neck cancer patients and seems to be correlated with intratumoral hypoxia. White blood cell counts can provide information about the body's immune response to the cancer or to the cancer treatment. We also have cytology tests. Sputum cytology is where we examine sputum for cancer cells, and it's often used for an initial screening. Fine needle aspiration retrieves cells from laryngeal masses for cytological evaluation. Imaging tests are not lab tests per se, but imaging tests like MRIs and CT scans often complement these tests. We'll go over those in more detail later. The nurse's role is, of course, order verification. Always confirm the lab orders and their specific protocols. For example, some tests require the patient to fast beforehand. Explain to patients what each test involves, alleviating any fears they might have about invasive tests like fine needle aspiration. and follow up with the results. Once tests are completed, ensure that the results are promptly communicated to the healthcare team for quick interpretation and action. Remember, each of these tests provides a different lens through which to view the patient's condition. As a nurse, you're often the first to collect this data and the first to see the results, so your prompt actions and keen observations make a significant impact on patient care. Laryngoscopy is a major diagnostic tool for diagnosing cancer of the larynx. So let's take a look at it. There are a couple different types of laryngoscopy. We have indirect laryngoscopy, which uses a light and a series of mirrors to visualize the larynx. It's very much less invasive, but offers very limited detail. We're generally going to be using direct laryngoscopy, which is where a laryngoscope is inserted directly into the larynx. It can be rigid or flexible, and this method provides a much more detailed view and the option for tissue sampling. So before the procedure, we're going to need to ensure that informed consent was obtained. Remember, it's the doctor or other provider's role to get informed consent. It's your job to ensure it was obtained. Clarify what the procedure will involve and the associated risks. Make sure that the patient does understand. If they don't seem to understand, get the provider back there to do a better explanation. Perform baseline vital signs as anesthesia or sedation might be used. Check for allergies, especially to anesthetic agents or contrast materials if used. During the procedure, we're going to monitor vital signs. They must be continuously monitored. Pay attention to oxygen saturation levels. Think about what we're doing here. Make sure the patient is as comfortable as possible, employing techniques to reduce anxiety. And in direct laryngoscopy, tissue samples may be collected for biopsy, so ensure correct labeling and transportation of those samples. After the procedure, you need to continue to monitor vital signs until stable. Inspect the oral cavity for any signs of bleeding or injury post procedure, and inform the patient about what was observed, next steps, and when to expect biopsy results if applicable. You're not going to be providing those results to the patient, that's the job, but you can give them some basic ideas. Make sure they understand when they're going to get that information. The nurse's role is documentation, accurately document the procedure, including any patient reactions for future reference. And before discharge, provide the patient with post care instructions, such as avoiding hot drinks that may exacerbate any throat irritation. Laryngoscopy is a cornerstone diagnostic tool in the assessment of laryngeal cancer. And as nurses, we have to play these roles before, during, and after the procedure, from patient education to monitoring vital signs, because that ensures not only the procedure's success, but also the comfort and safety of our patient. Now let's look at some imaging studies that might be used. A CT scan or computed tomography is utilized for detailed cross-sectional images. It's good for assessing the extent of tumor invasion in adjacent structures. An MRI or magnetic resonance imaging offers detailed images, especially useful for soft tissue assessment. It helps to evaluate the depth of tumor invasion. And a PET scan or positron emission tomography is utilized for staging and detecting distant metastasis. It can also assess the effectiveness of ongoing treatment. Our role pre procedure, again, is to ensure that informed consent forms have been signed, verify any allergies, particularly to iodine based contrast materials for CT or gadolinium contrast for MRI. Metal objects. Ask the patient to remove any metal objects, especially if what we're having is an MRI. We need to check renal function because the contrast used in CT and MRI can affect renal function. We need to ensure that baseline renal function tests are available. If the patient's using gadolinium, we need to watch whether or not they're taking metformin because that can delay our ability to get this test done. During the procedure, we're going to help properly position the patient on the examination table. And if contrast is being used, we're going to make sure they have a secure IV line for its administration. We'll keep a vigilant eye on vital signs and any signs of allergic reaction during contrast administration. Post procedure, we're going to encourage fluid intake to flush out any contrast material, monitor vital signs until stable, and look out for any delayed allergic reactions, and explain to the patient when and how they will receive their results. For documentation and follow up, we're going to record all relevant information, including the type of imaging, any use of contrast, and the patient's response, and ensure that the patient understands the importance of follow up appointments for results discussion and subsequent steps. A couple of special considerations. For MRI, be aware that the tunnel like structure can induce claustrophobia. Prepare to offer anti anxiety medication if necessary. And radiation, CT and PET scans do involve radiation, so confirm that the benefit outweighs the risk, particularly in pregnant patients. Each of these imaging studies has merits and limitations, and you'll encounter them at different stages of diagnosis and treatment. Your role as a nurse encompasses patient preparation, diligent monitoring, and thorough documentation. Safety considerations. Let's take a second to clarify the difference between emergent and urgent. Something that is emergent needs to be seen right now. Think of the word emergent like emergency room. Whereas something that's urgent does need to be seen, but it's not quite the same level. Urgent, like urgent care. Get it? Okay. Now that we have that well understood, let's look at some emergent scenarios in laryngeal cancer. First is acute respiratory distress, manifested by stridor, hypoxia, or cyanosis. This is a life threatening situation. Immediate intubation may be necessary, so prepare for emergency tracheostomy, initiate oxygen therapy, and alert the response team. We might have a massive hemorrhage, as indicated by brisk bleeding from the mouth or nose. We're going to need to initiate hemostatic measures, apply pressure if possible, and prepare for emergency surgical intervention. Blood transfusion might be needed. And then, of course, there's sepsis, which is rapid onset of fever, hypotension, and altered mental status. So, we'll be administering broad spectrum antibiotics as per hospital protocol, drawing blood cultures prior to that antibiotic administration, and closely monitoring vital signs. Now let's look at some urgent scenarios in laryngeal cancer. That includes things like voice changes, sudden worsening of hoarseness, or new onset vocal cord paralysis. We'll need to schedule immediate diagnostic tests and alert the oncology team. Adjust communication methods for the patient as well. New or growing masses in the neck or throat area requires us to coordinate prompt diagnostic imaging and possible biopsy. And if there's a sudden increase in pain levels not managed by current analgesic regimen, we'll need to assess the pain thoroughly, including location and character. Notify the healthcare provider for potential medication adjustments. We've also got to assess severity. So let's look at things like the ABCs: airway, breathing, circulation. You sick of hearing about those yet? They still work. Always assess these as your first priority. Look at vital signs and use these as immediate indicators to differentiate between emergent and urgent needs. The patient's own report is important, so listen to the patient. Subjective experience often provides clues to urgency. Our immediate steps include documentation. Timely and accurate documentation is critical, especially in emergent scenarios where legal implications could arise. And efficiently communicating the patient's status to all relevant healthcare professionals requires the use of SBAR: situation, background, assessment, and recommendation for effective communication. Always have emergency resuscitation equipment available and in working order. Don't forget the legal aspects. In scenarios, consent may be implied, but it's crucial to obtain explicit consent for procedures whenever possible. Always respect the autonomy and wishes of the patient, even in urgent and emergent scenarios. Complications. Let's look at some possible complications of laryngeal cancer. First is metastasis. This is the uncontrolled proliferation of cancerous cells from the primary site in the larynx to secondary sites in the body. Frequently, the cancer metastasizes to the lungs, liver, and bones, but it can also spread to the brain or the adrenal glands. Hemogenous spread through the blood and lymphatic spread are the major mechanisms. Your role is to maintain acute awareness of systemic symptoms like persistent cough, bone pain, neurologic symptoms, or jaundice. Coordinate with the oncology team for advanced imaging studies if systemic symptoms emerge. Administer any recommended systemic therapies like chemotherapy or targeted therapies and monitor for side effects. Airway obstruction is a life threatening condition where a blockage prevents air from entering the lungs. It could be caused by tumor growth obstructing the airway, inflammation due to radiation, post surgical edema, or even mucus plugs. Signs to look for are stridor, decreased oxygen saturation, and respiratory distress. Your role is continuous monitoring of respiratory rate, rhythm, and depth. Use pulse oximetry for O2 saturation levels and keep emergency airway equipment readily available. Be proficient in procedures like emergency intubation and tracheostomy if that's a part of your role, and be prepared to act instantly. Aspiration is accidental entry of foreign material into the lungs, leading to possible pneumonia or acute respiratory distress. Causes can be dysphagia due to the tumor, post-operative anatomical changes, or impaired consciousness. Signs include coughing, wheezing, fever, and a rapid heart rate. Your role? Implement aspiration precautions. Head of the bed should be elevated at least 45 degrees during feeding. Perform regular swallow assessments and auscultate lung sounds for any changes. Recommend speech therapy consults for swallowing evaluations. Hemorrhage is a sudden and potentially life threatening bleeding, which could be internal or external. Causes could be rupture of a tumor, post surgical bleeding, or radiation induced mucosal damage. Signs to watch for are tachycardia, hypotension, pallor, and sudden onset of coughing up blood. Your role: immediate action is critical. Administer prescribed hemostatic agents, apply pressure if the source is external, and activate the rapid response team. Monitor vital signs rigorously and prepare for possible transfusion or surgical intervention. Surgical complications include infection, poor wound healing, or fistula formation post surgery. Signs to watch for include redness, warmth, and discharge at the surgical site. Systemic signs like fevers or chills should be watched for too. Your role: strict adherence to aseptic technique for wound care. Monitor the surgical site visually and through palpation. Administer prophylactic antibiotics as ordered and coordinate closely with surgical teams for wound inspections and potential revision surgeries. There's also psychological complications. Mental health challenges like anxiety, depression, and stress are associated with life altering diagnosis and treatment. Signs to watch for include emotional withdrawal, changes in appetite and sleep patterns, and expressions of hopelessness or guilt. Your role: use validated psychological assessment tools to gauge emotional well being. Facilitate referrals to psychiatric care and counseling services. Provide emotional support and encourage the involvement of family and social networks. There's also treatment related complications, such as side effects arising from treatments like chemotherapy or radiation, including mucositis, xerostomia, and radiation dermatitis. Signs to include oral pain, difficulty swallowing, healing or redness of the skin in radiation areas. Your role: educate the patient and family about potential side effects and management. Coordinate with oncology for any dosage adjustments. Implement supportive measures like oral rinses for mucositis or creams for skin irritation. There may also be nutritional challenges. Significant weight loss and malnutrition can arise from decreased appetite, inability to swallow, or gastrointestinal side effects of treatment. Signs to watch for include wasting, fatigue, and low serum albumin levels. Your role: assess nutritional status using tools like the mini nutritional assessment. Coordinate with dietitians for a personalized, nutrient rich diet plan. If oral feeding is compromised, discuss options like nasogastric or percutaneous endoscopic gastrostomy, PEG, tube placement for nourishment. Each complication here demands meticulous attention and tailored nursing interventions. It's our role as nurses not just to identify these complications, but to act preemptively where possible to minimize their impact. This involves close coordination with multidisciplinary teams, ongoing patient and family education, and prompt emergency response when necessary. Let's look a little bit more closely at the psychological burden and mental health aspects. Mental health remains a critical yet frequently sidelined aspect in the management of laryngeal cancer. The psychological burden can manifest as anxiety disorders, depressive episodes, excessive stress, and existential crises, among other conditions. Neglecting mental health can result in poor treatment compliance, delayed healing, exacerbated physical symptoms, and an overall decline in quality of life. So it's your role to conduct comprehensive assessments that go beyond physical symptoms. Utilize standardized screening tools such as the Hospital Anxiety and Depression Scale or the Patient Health Questionnaire 9. Identify early signs of mental distress. This practice should be periodic and synchronized with other diagnostic or treatment cycles for better trend analysis. Patients may exhibit anxiety and fear. Anxiety refers to feelings of excessive worry, nervousness, or dread that can be either acute or chronic. These feelings are often coupled with apprehensive expectations of the diagnosis, treatment regimens, and long term outcomes. Common triggers are fear of mortality, the invasiveness of surgical procedures, potential side effects of chemotherapy or radiation, as well as anticipated lifestyle changes. Your role is to create an environment that encourages open dialogue. Offer clear and concise information to minimize uncertainties. Actively listen to patient concerns and validate their feelings. Collaborate with mental health professionals for appropriate pharmacological interventions and psychotherapeutic modalities like cognitive behavioral therapy or exposure therapy. Depression is a debilitating mood disorder marked by overwhelming feelings of sadness, hopelessness, and a disinterest in activities that were previously enjoyed. Signs to watch for are ongoing low mood, noticeable changes in eating habits, alterations in sleep patterns, irritability, and difficulty focusing. Your role is to establish trust and open communication. Regularly monitor the patient's compliance with both cancer treatment and antidepressant medication, as neglecting either could have cascading repercussions. Facilitate consultations with mental health experts for effective medication management and behavioral therapies such as CBT or DBT. Mechanisms are adaptive coping strategies, which range from problem solving and seeking social support to more introspective practices like cognitive restructuring. On the flip side, maladaptive coping mechanisms can include avoidance behaviors, denial, or substance abuse. Your role is to act as an educator by imparting knowledge about effective coping skills, discourage maladaptive techniques, stressing their long term detrimental effects. Advocate for resilience building activities such as mindfulness practices, meditation, physical exercise, and the inclusion of hobbies that bring joy and relaxation. Remember that the patient is not the sole carrier of this mental burden. It extends to caregivers and family members, altering their emotional states and coping capabilities. So, your role is to adopt a family centered approach to care by actively including family members in educational sessions, treatment discussions, and strategy planning as much as possible. Offer family members referrals to supportive services and resources, such as support groups tailored for caregivers of cancer patients. A substantial number of patients turn to spiritual or religious beliefs as coping tools, which can provide a sense of purpose and ease feelings of hopelessness. So, your role is to ensure that the hospital environment accommodates these spiritual practices, whether it's having a chaplain on staff, providing resources like religious texts, or creating a space for prayer and reflection. Remember that an immediate referral to psychiatric or psychological services becomes crucial when symptoms significantly impede daily living or if there's an expressed risk of self harm or suicidal ideation. Your role is to serve as an advocate for these patients by pushing for expedited interventions, maintaining a rigorous record keeping system that tracks the frequency and severity of mental health symptoms, and this allows for real time adjustments to the treatment plan. Facilitate and verify that follow up mental health appointments are not just scheduled, but also nursing care. Let's look at some things that need to happen preoperatively. We'll discuss the basic categories and then I'm going to explain what your role as the nurse is. So, there needs to be patient education covering topics like surgical techniques to be employed, the estimated length of surgery, possible complications, post surgical care like wound management, possible tracheostomy, and long term expectations such as speech rehabilitation and lifestyle changes. Most of this education should be done by the provider as a part of informed consent. But your role is to gauge the patient's comprehension by asking them to paraphrase the information given and to reinforce important points multiple times and involve family members in the discussion when appropriate. There needs to be a physical assessment, assessing not only vital signs, but also baseline respiratory function through tests like spirometry and assessment of cardiac function as it can be affected during anesthesia. Your role is to quickly report any deviations in baseline to the surgical team, as this may warrant a revision in surgical or anesthesia plans. And ensure that all preoperative labs, such as a complete blood count, coagulation profile, electrolyte levels, etc., are done and results are acknowledged by the surgeon. Well, there needs to be a nutritional assessment looking for signs of malnutrition, such as muscle wasting, loss of subcutaneous fat, or glossitis, checking for deficiencies in vitamins and minerals like vitamin K, which is vital for blood clotting. Your role is to refer cases of severe malnutrition to a registered dietitian and to coordinate with dietitians to create a robust dietary plan to accelerate postoperative healing. There must be medication reconciliation with a thorough evaluation of any anticoagulants, antiplatelet agents, or any medication that may impact kidney or liver function. Your role is to collaborate closely with the surgical team and the hospital pharmacist to ensure that medications are appropriately adjusted for the surgery, especially if the patient is on drugs that could interact with anesthetics or lead to post operations. There also needs to be some airway management prep. This prep work includes teaching the patient to expect potential changes in airway management postoperatively, such as reliance on a temporary tracheostomy. Your role is to provide any needed demonstrations on the use of tracheostomy sets or ventilators and practice basic airway clearance techniques like coughing and deep breathing exercises. There needs to be pain management. Choices need to be offered with comprehensive information on pharmacological options, opiates, NSAIDs, localized options like nerve blocks, as well as non pharmacological options such as guided imagery or breathing exercises. Your role is to formulate a detailed preoperative pain management plan in consultation with the anesthesia team, specifying the types, dosages, and routes of administration for analgesics. There must be psychological support. Factors include the patient's emotional well being, level of anxiety, and emotional preparedness for the surgical procedure. Your role is, if high levels of anxiety are detected, to engage mental health professionals like counselors or psychologists for preoperative sessions. Reassure the patient and family and answer all questions to the best of your ability to increase their satisfaction. Of course, there's always documentation and legal aspects. There's essential forms like informed consent, not just signed, but comprehended, and documentation of DNR, like do not resuscitate, or other advanced directives if applicable. Your role is to conduct a final verification where the surgical site is marked and the patient themselves confirms this mark. Document this entire process meticulously and ensure that the surgeon has done all of his job in marking the site and obtaining informed consent. Time management is essential. Make sure you're using a checklist. Validated surgical safety checklists help you to cross verify all preoperative steps from diagnostic studies to site marking. Your role is to confirm that the operating room is prepared for the patient's specific needs and ensure that transport to the OR occurs seamlessly and without any unnecessary delays. And of course, there's always final preparations, little last steps to make sure that the patient has no makeup on, nail polish, or jewelry on. Confirm that preoperative antibacterial bathing has been completed as required, and you double checking and administering any preoperative medications that have been ordered. Taking care to verify the rights of medication administration and ensure that the patient is in proper surgical attire, including hair covers and surgical gowns. By adhering to these exhaustive preoperative interventions, you contribute significantly to reducing surgical risks and enhancing patient outcomes. Every action you take, from assessments to planning, sets the stage for the surgical team's success and the patient's quick recovery. Okay, so you successfully got your patient down to surgery, but they're going to come back, and there's things that you're going to need to be aware of. When they come back, we need to do respiratory monitoring. We need to watch their oxygen saturation, maintain continuous SpO2 monitoring, watch for signs of stridor, wheezing, or shortness of breath. Immediate intervention with supplemental oxygen or bronchodilators may be necessary. Always keep suction equipment and an emergency tracheostomy set readily available. Watch vital signs and hemodynamic stability. For your blood pressure, keep an eye on both systolic and diastolic levels. Sudden drops may indicate bleeding. Tachycardia can be an early warning sign of hypovolemia. Promptly alert the surgical or anesthesia team if you notice drastic changes. Make sure to have resuscitation equipment on standby. Watch for pain and provide comfort management. Use standardized pain scales for assessments and document them thoroughly. Remember that you should have an analgesic protocol of opioids, NSAIDs, and local anesthetics. Make sure you're using what the physician has ordered, but if what the physician has ordered is not adequate, advocate for your patient and call and get a change in orders. You need to monitor for side effects like respiratory depression, especially when administering opioids. Offer non-pharmacological options like ice packs or guided imagery as adjuncts. For nutritional support, the patient may be on a liquid diet or enteral feeding initially. Slowly introduce soft, high protein foods as tolerated, and coordinate with the dietitian to assess nutritional status and caloric needs, aiming to support tissue healing and immune function. There's going to be a wound and there may be drains, so focus on that surgical site. Look for signs of infection, such as increased redness, swelling, or discharge. Monitor any drainage amount and color, and perform sterile dressing changes as prescribed. Empty drains at regular intervals, maintaining meticulous documentation of not just the amount of output, but color, smell, thickness, things like that. You need to provide psychological support. So, watch for any depression or anxiety from your patient. These are common postoperative symptoms, but they interfere with recovery. You need to encourage open communication, arrange for psychological counseling if necessary, and keep the family informed and involved in emotional support. Once again, we get to do medication reconciliation. We do that a lot. Medications may be changed post op, particularly anticoagulants or antihypertensives. So you need to confirm any new medication orders and ensure that all healthcare team members are updated on the changes. Mobility and physical therapy are super important. They help to reduce complications. Early mobility is key to preventing venous thromboembolism and pneumonia. So initiate early ambulation protocols, supervise physical therapy sessions, and provide any necessary aids like a walking frame. Discharge planning starts at admission, but it absolutely must be started and continued postoperatively. You need to teach patients and families about at home care, potential complications, and when to seek immediate medical attention. Arrange any appointments with surgeons or other specialists for postoperative evaluations if you can, and ensure that all discharge medications are confirmed and that the patient comprehends all instructions. Document, document. Document all interventions, observations, patient responses, and any changes in medical orders. The medical record should be comprehensive, facilitating smooth handovers and contributing to evidence based care. By adhering to these comprehensive postoperative nursing interventions, you will not only facilitate rapid patient recovery, but also preempt and manage potential complications. Each step, from meticulous monitoring to supportive therapies, is crucial for optimal patient outcomes. Medications. Let's take a look at some of the chemotherapy used in treating laryngeal cancer. First off, we've got cisplatin. This is a platinum based medication that causes DNA cross linking, leading to cell death. Side effects are nephrotoxicity, so it's hard on the kidneys, nausea, and ototoxicity. That means it's hard on your hearing. It interacts with diuretics and nephrotoxic drugs. Another medication often used is 5-FU or fluorouracil. This is a pyrimidine analog. It disrupts the DNA and RNA synthesis of the cancer. Side effects are myelosuppression, mucositis, and it interacts with warfarin and phenytoin. Another common medication is carboplatin. It's less toxic, but otherwise similar to cisplatin. The side effects are myelosuppression and nausea. And the other interactions are similar to cisplatin, like diuretics and nephrotoxic drugs. Then we've got some secondary medications that are often used, docetaxel and paclitaxel. These are taxanes. They stabilize microtubules, which block cell division. Side effects can include neutropenia and peripheral neuropathy, and it interacts with CYP3A4 inhibitors like ketoconazole. So our role is to have a detailed knowledge of mechanisms, side effects, and interactions. So please go back and do a med card for each of these medications. We need to be ready for pre-medications and adverse effect management. These medications are going to be delivered sometimes through an IV infusion, particularly initially as we're getting things set up. And for that, sterile technique is mandatory. It remains mandatory once you get a port or central line, but just be aware that you've really got to be careful with your IV infusions with your cancer patients. If they're going to be getting long term treatment, which most of them will, they will be getting a port or a central line. You need to always confirm identity, drug, dose, the rights. Watch for any immediate allergic reactions and be ready to manage any extravasations because these medications are really hard on the veins. There are side effects that are common to all these agents, and that's things like myelosuppression. This is going to require periodic CVCs. And gastrointestinal issues managed with antiemetics. And when we get into the module, you're going to really have a good understanding as to why it affects these particular things. But we're not getting into that here. There are also agent-specific side effects, such as cisplatin being autotoxic. So you're going to have to run auditory tests to see what the effect is on the hearing for your patient. And then the 5-FU is mucositis, so we're going to require mouth care protocols. Your role is to conduct baseline and ongoing assessments and to educate and provide any needed interventions. Common complications from chemotherapy is things like tumor lysis syndrome. Tumor lysis syndrome occurs when tumor cells release their contents into the bloodstream, either spontaneously or in response to therapy. And this can lead to hyperuricemia, hyperkalemia, hyperphosphatemia, and hypocalcemia. So make sure you're monitoring for any electrolyte imbalances. We could also end up with a neutropenic fever. This is when there's a single oral temperature greater than or equal to 100 degrees Fahrenheit or 38.3 degrees Celsius, or a temperature greater than or equal to 100.4 degrees Fahrenheit, 38 degrees Celsius, for at least an hour, along with an absolute neutrophilic count, ANC, of less than 1,500. This requires immediate intervention, and you should be drawing cultures, one from each lumen of a central line and one peripheral culture, or two peripheral cultures if a central line is not present. And of course, there's always anaphylaxis, which you guys know that's an immediate life threatening condition. Your role is timely identification and urgent action, including medication administration and team coordination. There are some drug interactions and contraindications that you need to be aware of. If you have a patient with renal impairment, you do need to avoid cisplatin. If you have a patient with liver impairment, you need to get a consult because they need to be really looking at that 5-FU medication dose and adjusting it if needed. So make sure you're thoroughly reviewing the medication list, lab results, and your patient's medical history before initiating any of these medications. Contact the physician if you have any concerns and educate them on avoiding any unsupervised over the counter drugs. Those are not okay right now. Okay. We have to know what's going into them. For patient education and monitoring, we need to make sure that the patient understands the treatment objectives and the need for regular testing. And we need to ensure that regular monitoring, including CBC, renal, and liver function tests, are done and educate them on emergency symptoms like uncontrolled bleeding or high fever that they need to report. There's always going to be long-term surveillance when you're talking about patients. So long-term, we're going to be repeating these CBC, liver and renal function tests, imaging for tumor assessment. And our role is to schedule and emphasize the significance of these tests to the patient for long-term better outcomes. Document, document, document. Include every step from consent to drug administration, patient response, and any adverse events. By understanding the intricacies of these chemotherapy agents, their interactions, and their possible side effects, you can perform your role effectively and ensure patient safety and optimal outcomes. Let's take a look at some of the chemotherapy used in treating laryngeal cancer. First off, we've got cisplatin. This is a platinum-based medication that causes DNA cross-linking, leading to cell death. Side effects are nephrotoxicity, so it's hard on the kidneys, nausea, and ototoxicity. That means it's hard on your hearing. It interacts with diuretics and nephrotoxic drugs. Another medication often used is 5-FU or fluorouracil. This is a pyrimidine analog. It disrupts the DNA and RNA synthesis of the cancer. Side effects are myelosuppression, mucositis, and it interacts with warfarin and phenytoin. Another common medication is carboplatin. It's less toxic, but otherwise similar to cisplatin. The side effects are myelosuppression and nausea, and the other interactions are similar to cisplatin, like diuretics and nephrotoxic drugs. Then we've got some secondary medications that are often used, docetaxel and paclitaxel. These are taxanes. They stabilize microtubules, which block cell division. Side effects can include neutropenia and peripheral neuropathy, and it interacts with CYP3A4 inhibitors like ketoconazole. So our role is to have a detailed knowledge of mechanisms, side effects, and interactions. So please go back and do a med card for each of these medications. We need to be ready for pre-medications and adverse effect management. These medications are going to be delivered sometimes through an IV infusion, particularly initially as we're getting things set up. And for that, sterile technique is mandatory. It remains mandatory once you get a port or central line, but just be aware that you've really got to be careful with your IV infusions with your cancer patients. If they're going to be getting long-term treatment, which most of them will, they will be getting a port or a central line. You need to always confirm identity, drug, dose, the rights. Watch for any immediate allergic reactions and be ready to manage any extravasations because these medications are really hard on the veins. There are side effects that are common to all these agents, and that's things like myelosuppression. This is going to require periodic CBCs. And gastrointestinal issues managed with antiemetics. And when we get into the module, you're going to really have a good understanding as to why it affects these particular things. But we're not getting into that here. There are also agent-specific side effects, such as cisplatin being autotoxic. So you're going to have to run auditory tests to see what the effect is on the hearing for your patient. And then the 5-FU is mucositis, so we're going to require mouth care protocols. Your role is to conduct baseline and ongoing assessments and to educate and provide any needed interventions. Common complications from chemotherapy is things like tumor lysis syndrome. Tumor lysis syndrome occurs when tumor cells release their contents into the bloodstream, either spontaneously or in response to therapy. And this can lead to hyperuricemia, hyperkalemia, hyperphosphatemia, and hypocalcemia. So make sure you're monitoring for any electrolyte imbalances. We could also end up with a neutropenic fever. This is when there's a single oral temperature greater than or equal to 100 degrees Fahrenheit or 38.3 degrees Celsius, or a temperature greater than or equal to 100.4 degrees Fahrenheit, 38 degrees Celsius, for at least an hour, along with an absolute neutrophilic count, ANC, of less than 1500. This requires immediate intervention, and you should be drawing cultures, one from each lumen of a central line and one peripheral culture, or two peripheral cultures if a central line is not present. And of course, there's always anaphylaxis, which you guys know that's an immediate life threatening condition. Your role is timely identification and urgent action, including medication administration and team coordination. There are some drug interactions and contraindications that you need to be aware of. If you have a patient with renal impairment, you do need to avoid cisplatin. If you have a patient with liver impairment, you need to get a consult because they need to be really looking at that 5-FU medication dose and adjusting it if needed. So make sure you're thoroughly reviewing the medication list, lab results, and your patient's medical history before initiating any of these medications. Contact the physician if you have any concerns and educate them on avoiding any unsupervised over the counter drugs. Those are not okay right now. Okay. We have to know what's going into them. For patient education and monitoring, we need to make sure that the patient understands the treatment objectives and the need for regular testing. And we need to ensure that regular monitoring, including CBC, renal, and liver function tests, are done and educate them on emergency symptoms like uncontrolled bleeding or high fever that they need to report. There's always going to be long-term surveillance when you're talking about patients. So long-term, we're going to be repeating these CBC, liver and renal function tests, imaging for tumor assessment. And our role is to schedule and emphasize the significance of these tests to the patient for long-term better outcomes. Document, document, document. Include every step from consent to drug administration, patient response, and any adverse events. By understanding the intricacies of these chemotherapy agents, their interactions, and their possible side effects, you can perform your role effectively and ensure patient safety and optimal outcomes. Now let's look at some targeted therapies. I'm not going to give you specific medication names for this. I just want you to understand the basic categories that are going on here. So first we've got epidermal growth factor receptor inhibitors or EGFR inhibitors. These drugs block EGFR proteins that are on the surface of cancer cells, and this is their growth and division. Side effects include rash, nail changes, mouth sores, and low magnesium levels, and this can result in seizures if it's unchecked. So be checking those MAG levels. Drug interactions, they may interact negatively with other chemotherapy agents or antiviral medications, potentially elevating toxicity levels. So we're going to monitor for skin reactions and GI symptoms and always check magnesium levels before administering the drug. The next category is monoclonal antibodies. They inhibit vascular endothelial growth factors, VEGF, and this limits the tumor's blood supply. However, there is a risk of severe bleeding, hypertension, proteinuria, and they should not be administered alongside anticoagulants due to the increased risk of bleeding. So, strictly monitor blood pressure and protein levels in the urine and keep emergency equipment ready for any bleeding events. The next kind is kinase inhibitors. These inhibitors block specific kinases that play roles in cell signaling pathways and angiogenesis. So this leads to more control of the tumor growth. It doesn't cause it to cease; it just puts it more controlled, so that other therapies have a chance to work. Side effects are hand-foot syndrome, diarrhea, hypertension, and fatigue. And the drugs can have interactions, IP3A4 enzyme inducers or inhibitors, so this alters their effectiveness. So you need to closely observe for changes in skin integrity, monitor blood pressure, and frequently check liver function tests. Your role in using targeted therapy is that prior to administration, you need to complete any baseline assessments. That's going to be things like a CBC, liver and kidney function test, and possibly cardiac evaluation, just depending on what targeted therapy we're looking at. And then, of course, medication reconciliation. Thoroughly document all ongoing medications, including any over the counter drugs, vitamins, and herbal supplements to avert adverse interactions. You need to understand that patients will not volunteer this information. It doesn't even occur to them sometimes. When you ask them what medications they're on, they might not think to tell you herbal supplements or anything that's outside of the norm of prescription medications. Sometimes it's because they're afraid you're going to judge them. Sometimes it's just because it doesn't occur to them. So you need to specifically ask about these things so that you can monitor for any interactions. Very, very important. Now, during administration of these medications, we're going to be monitoring. We're going to conduct hourly vital signs checks, watch for symptoms of allergic reactions or any infusion reactions. Obviously, confirm all of the rights, drug name, dosage, route, timing, but you want to confirm all of these rights with another nurse and ensure that the rate of infusion is in accordance with the guidelines. This is a two-nurse check. After the administration, you need to maintain a high level of surveillance for immediate and delayed side effects, such as anaphylaxis, breathing difficulties, or a sudden drop in blood pressure. Let's talk about side effects and management of side effects. So, there's going to be skin reactions. Almost almost always there's skin reactions of some sort. So you need to use topical corticosteroids or antibiotics like mupirocin. Inspect the skin for any redness, chapping, or any signs of secondary infection, and provide them with skincare products like emollients and educate them on proper application. There's almost always gastrointestinal issues as well. So you're going to administer antiemetics like ondansetron before therapy and antidiarrheal medications like loperamide as needed. Offer dietary counseling for managing symptoms, actively monitor for dehydration, and weigh the patient daily to assess fluid status. There may be cardiovascular concerns. Use of antihypertensives like amlodipine, beta blockers may be needed if these are causing hypertension. Monitor their blood pressure at least every 4 hours when awake, heart failure like edema or shortness of breath, and provide daily weight and fluid intake output charting. For follow up and ongoing monitoring, please make sure your patients know that they need to get regular testing. We're going to be testing liver and kidney function tests, electrolyte balance, and any additional tests depending on which targeted medication they're using. You've got to help with scheduling the tests, informing the medical team immediately of any abnormal results, and documenting all test results meticulously. Please provide thorough patient education. Make sure they know what symptoms need immediate medical attention, like severe headache, chest pain, or sudden weight gain. Be proactive teaching. Use teaching aids, offer printed material for home reference, and validate understanding through return demonstrations or questions. Document, document, document. So, comprehensive notes on medication name, dose, route, time, response, any side effects noted, and nursing interventions that were undertaken to manage those side effects. And please conduct frequent medication adherence checks, document any instances of skipped doses, the patient modifying the dose on their own, and any patient reported side effects or difficulties with the medication. Those are the things that lead them to modify the dose on their own, which they should not be doing. By having in-depth knowledge of the targeted therapies, their mechanisms, and possible complications, you can be vigilant and proactive and ensure the highest. Let's look a little closer at managing side effects, specifically looking at antiemetics. So there are different types of antiemetics that we might use when taking care of our laryngeal cancer patient. The first type is serotonin antagonists, and that's things like ondansetron. The mechanism of action here is that these drugs inhibit the 5-HT3 receptor, and that diminishes the vomiting reflex. But they can cause headaches, dizziness, and constipation, and they interact with certain SSRIs, which increases the risk of serotonin syndrome. So always assess for serotonin syndrome symptoms like agitation or high fever, and regularly monitor bowel movements and advise patients to report any irregularities. We might use a dopamine antagonist, and that's things like metoclopramide, prochlorperazine. The mechanism of action here is that they block dopamine receptors in the central nervous system, and that suppresses nausea and vomiting. They may cause some extrapyramidal symptoms, sedation, and hypotension, and they are contraindicated with antipsychotics due to the risk of additive sedation. So, actively monitor for acute dystonia or any Parkinson like symptoms, and make sure to regularly measure blood pressure and alert the medical team if hypotension occurs. Uh, Interestingly enough, we might actually use corticosteroids like dexamethasone. The precise mechanism for how this is antiemetic is unknown, but likely it involves reducing inflammation. There is a potential for fluid retention, hyperglycemia, and mood swings, and it may reduce the efficacy of anti-diabetic medication. So, consistently check blood sugar levels in your diabetic patients and assess for changes in mood or behavior, especially any signs of depression or anxiety. Other nursing interventions and monitoring you need to do before administration, obviously, confirm allergies and consult about any other medications they're taking and perform baseline vitals and brief the patient on what to expect during antiemetic therapy, such as potential side effects and their likely duration. Always double check the drug name, dose, route, and so on with another nurse because when we're dealing with cancer patients, we can't be too careful. Vigilant monitoring of vital signs, especially blood pressure and pulse, needs to happen. And then reassess the effectiveness of the medication, looking for reduced nausea and vomiting, but also any new symptoms. And keep meticulous records of the drug's efficacy, noting the patient's subjective reports as well as any objective observations. So, you want to provide some dietary advice, tips on foods that are easier to tolerate, and how to handle nausea through diet, like opting for blander foods or smaller frequent meals, and stress the importance of them immediately reporting any enduring or increased symptoms, or if new symptoms like dizziness or palpitations arise. Document in detail the type of antiemetic administered, dose, route, time, any observed side effects, and steps taken for symptom management. And make sure to update the medication chart to include the antiemetic, especially if this is a newly added medication. This helps to ensure ongoing safe practice. Now let's look at the other major side effect that we're going to be working on, and that is pain control. So we might be using an opioid analgesic such as morphine, fentanyl, oxycodone. These bind to opioid receptors in the central nervous system and inhibit pain signals. But the side effects are respiratory depression, constipation, nausea, and of course, there are always dependency risks, and they're contraindicated with alcohol, benzodiazepines, or other CNS depressants. So, rigorous respiratory monitoring is crucial, and advise patients about the risk of possible dependence and establish a bowel regimen to mitigate constipation. There's also non-opioid analgesics like acetaminophen and ibuprofen, which inhibit COX enzymes, which reduces prostaglandin production and inflammation, but there is potential liver toxicity or GI issues, increased risk of bleeding when taken with anticoagulants. So periodically, we're going to be checking liver and kidney function tests, and please caution your patients against using any over-the-counter NSAID without provider consultation. Super important that we're aware of what's going on because of how toxic some of these medications can be for our cancer patients. We might use an adjuvant analgesic such as gabapentin or amitriptyline. Obviously, the mechanism of action of these are going to vary depending on what we're using, but they include inhibition of pain pathways or modulation of neurotransmitters. It could cause sedation, dry mouth, blurred vision, things like that. They may have potential synergistic sedation effects if combined with other CNS depressants. So, warn patients about the potential for sedation, especially if they're going to be operating machinery, and monitor for visual changes or excessive dry mouth and report this to healthcare providers. Before administration, use pain scales to assess patient pain levels. This will help to determine the type and origin of pain and confirm any allergies and cross reference with current medication lists for interactions. Always double check the drug, dose, route, all of the, six rights, and observe for any immediate side effects such as allergic reactions or changes in respiratory rate. After administration, assess pain relief. Make sure it's working. Use the same pain scale you used before. If pain persists, we might need to escalate this to the provider because it's not working. Keep thorough records, document pain level changes, medication administered, and any adverse effects. Make sure to teach patients how to safely store and dispose of opioids to minimize the risk of accidental ingestion or misuse, and instruct patients to report any difficulties like constipation, breathing issues, or uncontrolled pain immediately. Make sure you document. Always update the medication administration record, including dosage time and observed effects, and keep the entire healthcare team updated through shift reports and report any significant changes in the patient's pain status. Client education. When we educate the patient and the family, we need to use a holistic approach, go beyond the medical jargon and treatment protocols to engage the patients in understanding the importance of holistic wellness. Stress at managing laryngeal cancer is a comprehensive effort, encompassing things like dietary changes, emotional resilience, and even spiritual well being. Equip patients with skills to create holistic wellness plans, touching on aspects like nutrition, exercise, stress management techniques, and spirituality, depending on the patient's beliefs and interests. Clarify that understanding the nuances of their condition can positively influence their commitment to their treatment. A knowledgeable patient is less likely to skip medications, miss appointments, or disregard post-treatment guidelines. Provide data on success rates or improvement metrics for patients who actively participate in their care, and emphasize the importance of compliance with medical advice and procedures. There are some specific areas that we do need to address, such as understanding their diagnosis. We need to make sure they understand the anatomy of the larynx, how cancer affects this area. Make sure to clarify the implications of the specific type and stage of the patient's cancer, elaborating on how it affects prognosis and treatment choices. And distribute written materials, such as booklets or handouts, alongside visual aids like anatomical models or diagrams, and ensure that these resources are accessible and easy to understand. Treatment options. Make sure that you've reviewed their treatment options. Explain the mechanisms of how they work, their success rates, and their side effects. Highlight that the chosen treatment plan is tailored to the individual and may include a combination of surgical and non-surgical treatments. If you can, offer case studies or examples to illustrate the efficacy of different treatment approaches, taking care never to promise a guarantee, but do offer well-informed hope. You need to offer a comprehensive guide to manage common and less common side effects, including suggested dietary changes, physical exercises, or sleep routines that could alleviate discomfort. And if relevant, recommend over-the-counter products that could be useful, and provide names of reliable brands for items like mouthwash for dry mouth or creams for skin irritation. And emotional and psychological support. Direct patients to reliable mental health professionals specializing in oncology. Share testimonials or success stories from previous patients who have benefited from psychological counseling if you have them. And explain the neuroscience of stress and its detrimental impact on physical health, advocating for mental health support as a vital part of recovery and well-being. Now, I recognize a lot of these things are things that the doctor should have gone over with them, but please remember, patients are often gobsmacked when they first get their diagnosis, and they may not be taking information in well, and you may need to repeat things 3, 4, 5, 6 times with patients so that they can really get what's going on. This is a stressful time, and it's hard to learn when you're stressed. We need to provide hospital resources, let them know how to access a library of hospital-compiled resources, brochures, video content, interactive webinars if these are available. Specify any hospital departments that offer support services like nutritional consultations, physiotherapy, or stress management workshops. You might have online resources. Offer a list of reputable medical websites or patient forums that provide accurate and actionable information. Clearly explain the markers of reliability, such as peer reviews, medical accreditations, and references to scientific studies. And if possible, detail local services and organizations that offer support, like transport services for medical appointments or meal delivery options tailored for cancer patients. Discuss any affiliations a hospital may have with local or national cancer support organizations that can offer subsidized services. For the family and caregiver, make sure that you're suggesting workshops or educational sessions specifically designed for caregivers. Provide comprehensive packages that can serve as at-home reference materials for family members. And discuss techniques for effective communication within the family unit, especially concerning how to discuss the illness, treatment, and expectations without causing undue stress or misunderstandings for anyone in the family. Document. Note the significance of thorough documentation for legal and treatment purposes. Document the date, time, and core content of each educational session, along with any materials provided. And propose scheduled educational follow-ups, complete with preparatory reading or activities. Encourage patients to come prepared with questions, and keep a record of these inquiries so that the answers provided can be used to track progress and tailor subsequent sessions. Make sure to refer to the provider or other professionals as appropriate and don't step outside your scope, but understand that often the person they trust the most is the nurse. So you need to be the person who can help to interpret medical jargon, just in case their other providers are not very good at that. Now let's talk follow-up. Please reinforce the necessity for consistent follow-ups to monitor for late complications like tracheal stenosis, xerostomia, or dysphagia, which can occur months or even years post-treatment, and present data on how regular checkups have helped to catch these complications early, resulting in better management and reduced morbidity rates. Explain that laryngeal cancer, like many cancers, has the potential to recur. Discuss the statistical likelihood based on the stage and type of cancer initially diagnosed and treated, and explain why specific tests such as PET scans, MRI, or tissue biopsies may be part of regular follow-up schedules to monitor for cancer recurrence. Go over the frequency and nature of follow-up appointments. Describe that the first few months post-treatment will typically involve much more frequent visits. Discuss the common schedule like bi-monthly or quarterly visits depending on the oncologist's recommendation, and detail what each visit usually entails, from physical examinations to specific tests like blood work or imaging studies. And then discuss how these taper off in appointment frequency as more time passes post-treatment. Point out that even after years, annual reviews are still highly recommended. And explain the nature of these appointments change over time, focusing more on general health and less on cancer-specific markers, but we still need to be alert for any possible recurrences. Make sure they understand personal responsibility and lifestyle changes. Mention the importance of dietary changes in reducing the risk of recurrence, such as increasing the intake of antioxidants through fruits and vegetables and reducing alcohol and tobacco use. Recommend dietary consultation services where detailed individualized plans can be created. And note the benefits of regular exercise in improving general health and potentially reducing the risk of cancer recurrence. Emphasize that activities should be tailored to each patient's physical condition post-treatment. Also make sure to manage emotional and psychological issues. So address anxiety. Discuss the common psychological phenomenon of scanxiety. That's anxiety related to scans or test results, and the ways to cope with this through stress management techniques such as mindfulness or controlled breathing. Share resources for emotional support like counseling services or support groups specifically designed for cancer survivors. Detail how these platforms help in dealing with the emotional toll of regular follow-ups. Make sure they know what red flags there are. Educate them on symptoms that should not be ignored between follow-up appointments, such as persistent cough, unexplained weight loss, or changes in voice, and these necessitate immediate medical consultation. And explain what steps should be taken in case these red flag symptoms arise, whether it's directly contacting their oncologist or visiting an emergency room, and what kind of immediate tests may be conducted. There is a family and caregiver role here as well. Stress the need for caregivers to be well-versed in recognizing signs of complications and offer training modules or resources specifically for caregivers to enhance their competency, but also highlight the role of family and caregivers in providing emotional support during follow-up phases. Note that emotional well-being can significantly affect a patient's overall health and can potentially influence recurrence rates. By following a rigorous and well-structured follow-up schedule and lifestyle modification plan, both patients and healthcare providers can maximize the chances for successful long-term outcomes and reduce risks associated with laryngeal cancer recurrence and complications. So we've covered a lot of ground in this presentation, from comprehensive assessment, safety and complications, important nursing interventions, pharmacotherapy, and client education. By reviewing this material and making sure you have a good grasp of it, you'll be able to provide the best possible care for your patients who have laryngeal cancer.